do with the acid-base balance. And we also appreciated that 180 liters of filtrate it passes through the kidneys on a daily basis. So friends, today, still continuing with our different systems, today we are going to be looking at nutrition in the pulmonary diseases. And when we are talking of pulmonary here, we need to think of one thing, and those are the lungs. Okay. You remember at the start of our engagement, I told you that the conditions can all never be covered in our day-to-day lives or in our day-to-day lectures. And what we need to note is that going forward, people need to do their own research. Okay, you need to put something into this body of knowledge. You need to come and contribute, because whatever is being discussed here is research that was done by someone. Okay, so it is the same research that we are also doing as of today, or it is the same thing that we are trying to study from. So it is those gaps that you will be able to find, and you will know that new conditions are developing every now and then. And it will be upon you as the people who are taking on sciences to find those solutions to help the world at large. So today we are going to be looking at nutrition in pulmonary diseases. And we're saying to understand one of these are our objectives for today. It's going to be a little brief, and we are saying one of them is to understand the role of nutrition in prevention, management of pulmonary diseases, all the diseases affecting the respiratory system, I should say, and to identify the nutritional risk factors and consequences of the pulmonary diseases, and also to assess the nutritional status and the needs of patients with these pulmonary diseases. I hope most of us were present when we were discussing nutrition assessment. Okay. Yeah, and we understood the methods of assessment, beginning with anthropometry, looking at the biochemical assessment, the dietary history, and also the clinical assessment, where we are looking at the signs and symptoms presenting in an individual. Really, also, we are going to be able to implement evidence-based nutrition interventions for those patients with these pulmonary diseases. And also we'll be able to evaluate the effectiveness and outcomes of these interventions for the patients with the pulmonary diseases using those relevant indicators. You remember when we were talking about the nutrition care pathway, or the nutrition care process, as some might term it, and we say this is a standardized form of care which is systematic, step by step. And you remember when we were talking about the first one being the first one being nutritional assessment. Then after assessing, you do the diagnosis. After doing the nutrition diagnosis, when we talk of diagnosis, you realize that we will at least travel back to the NCP and we show you how do we write a diagnosis in a nutrition way or in a nutrition conversant manner, so that any nutritionist can read whatever diagnosis you're writing. It is the same that happens when people are in medical school. Whatever diagnosis one doctor makes, then the other doctor can ably interpret. But we will see that later on in our engagement. Yeah, you realize, I promise us that we'll see everything later, but really it is the time factor. But we will organize and find ways of patching up all those holes and all those gaps that we are leaving behind. All right, so what I was trying to bring to our notice is when we are talking, rarely do we talk of evaluating the effectiveness of our outcomes. Okay, so once someone does a nutrition intervention, you as a person, you need to closely monitor, you need to closely evaluate, and this helps you deal with other conditions better. Okay, and it's what how we talk about the documentations. This is how we find those missing gaps and the links, okay, to overall health and helping people's lives and helping people live better lives. So friends, we are looking at this and we are saying that this is a nutrition in the pulmonary diseases, and we are saying pulmonary diseases like asthma and the chronic obstructive pulmonary disease has significant causes of mortality, or what you call death. Okay, so when we talk of this chronic obstructive pulmonary disease, we are looking at a group of those lung diseases that really make it hard for people to respirate or to breathe. And most of them are those bronchitis. As we will see, over much, there has been a lot of theory and also a lot of evidence that links most of these pulmonary diseases to smoking and also exposure to those lung irritants. Not whoever will come to you with a pulmonary disease has been a smoker. We have passive smokers too, and also we have people who are working in those manufacturing plants. Okay, they are not actively smoking, but then they are being exposed to the smoke. At the end of the day, these people are going to get sick with these pulmonary diseases, and really we will be dealing with them quite often. Yeah, so mostly the treatment focuses on managing some of those symptoms, and we are saying the nutrition strategies are integral in the treatment of these conditions. Right. So when we talk of asthma, really, in asthma's case, we are looking at the chronic inflammatory disease. Okay. Asthma really, for most people, people tend to say asthma will go with age, but rarely does it go with age. Sometimes asthma stays there for quite a number of time because it leads to the narrowing of the airway, and this will cause those symptoms, the sneezing, the wheezing, and also you will feel that these people lose breath. I think that is what we call losing the breath. And really, it is always challenging when you're having these asthmatic clients. Because some of these these things can be triggered by allergens, and like I told you, allergens are found everywhere. They are found in food, they are found in pollen, and some of them are just normally existing or naturally existing in our atmosphere. So really, that is what we can talk about asthma. And for those symptoms, like I've told you, the chest tightness, and it makes it very improper for someone, or it makes it very difficult for people to breathe. Okay, since now the airways that are taking into the air into the lungs are being narrowed down, and also other things, respiratory diseases or infections could cause this. But also, some people have said that whenever they do these strenuous exercises or whenever they engage in those strenuous activities, these people onset those episodes of asthma, the wheezing. You hear that sound whenever an asthma client is closer to you. You will be hearing whenever they exhale or they inhale, you will be hearing a sound as if someone is blowing a whistle or something like that. Yeah. So those are the signs and symptoms. And we are saying management usually focuses on symptom control. We are trying as much as possible to find a way of managing this. And there is also an association with overweight and obesity. So we are now looking at overnutrition. With overweight, you remember our cutoffs. If it is the BMI, we're using BMI to categorize overweight or obesity. You remember our cutoffs and you remember the calculations. So for the weight loss, will help us improve the lung function and also the quality of life of an individual, because really it is painful. You're already seeing these people with asthma putting on scarves. We are not only saying that it is the overweight or the obese clients, but really we find that these people who are having asthma, most of them have a lot high weight for their height. Okay, really, treatment. When we are talking of weight loss improving, we are also looking at treatment. Like I told you, nutrition does not work alone. We work with the people, with other people in the health sector. So you will hear the bronchodilators, you will hear of the inhalers that people are using, and this will also help us trying to relax the airway muscles, and also those corticosteroids Whenever you hear the word of corticosteroids, you're thinking of reducing the inflammation bit of it. And also, we are saying we tend as much as possible to avoid those things that trigger these sessions or these episodes. For example, if it's pollen, if it's those allergens, if it is the cold air, whenever it's cold, you find a way of warming up the individual so that we can help. And also, a health diet can help manage some of these symptoms. Okay, yeah, so we are saying there is no cure, but symptom management is very crucial. Whenever we tend to work on these cases, people can say that asthma goes away with time. It's just that now it becomes very mild, but really it does not go away. And we are saying dietary changes may not consistently impact the clinical outcomes. Okay, yeah, an energy restriction of 7.5% weight loss improves lung function and mobility. Okay, yeah, when we talk about losing a little bit of weight, you will see that now the lungs can function a little better compared to if the person was still overweight. And we are saying lifestyle changes for health weight reduction in overweight or obese asthmatic individuals are key. So, if you get people with asthma, however much you're not going to be recommending very many things under the docket of nutrition, you can able to talk about the lifestyle changes. And you realize that now lifestyle changes are a challenge compared to these other things that we can see. Because once someone's lifestyle can change, then we can work on these other things. We can work on the calorie counting. We can work on the diet plans. But it comes from within an individual. It comes from the thought that, okay, now there is desire to change, whether for the perceived benefits or the perceived threats of this person developing those cardiovascular diseases, I should say. So let's look at the chronic obstructive pulmonary disease. And for the chronic obstructive pulmonary disease, a group of these progressive lung diseases that make it hard to breathe. Okay, and we are saying it is a systematic disease which will encompass chronic bronchitis, emphysema, and also the small airways disease, and chronic inflammation leading to tissue damage. Okay, and symptoms include chronic cough and sputum production. So, friends, don't think I'm having a chronic obstructive pulmonary disease. It's just that I lost my voice midway, but I had to show up for the lecture today because there is a lot for us to cover. Okay, so how do we diagnose this? And we are saying we diagnose this by using spirometry. When we talk of spirometry, this is a very, very common test that measures how much or how quickly you can move the air out of your lungs. Okay, so it is used to diagnose and monitor people with chronic obstructive pulmonary disease. Okay, yeah, even people with asthma, sometimes it will help them. So here you breathe into this mouthpiece attached to the spirometry, and it records the amount of speed of air that you breathe in and out. So that is how the spirometry works. Okay, yeah, and we're saying for this chronic obstructive pulmonary disease, treatment focuses on the symptom management and also slowing down the disease progression. We are trying as much as possible to limit the inflammation to prevent further tissue damage. Okay, and when we talk of tissue damage, you know what things we need to indicate here to repair the tissues, to repair the muscles. And you will see that now we will have to increase on our protein intake. Okay. Yeah, and also lifestyle changes, which will include smoking cessation and pulmonary rehabilitation, are very crucial. When we talk of including smoking cessation, really now we understand that there is a problem. When problems are still mild, we still have a leeway of talking to someone and finding ways in which they can change their lifestyles. But if things have escalated, if we are now in the chronic obstructive pulmonary disease and the stages are progressing, we need to find ways, we need to find ways in which our interventions are being affected by the lifestyle choices of these patients or of these individuals. For example, we can't be as much as possible trying giving the corticosteroids and etc. to slow down the inflammation, and the individual is still smoking. So most of these clients, we need to be a little frank with them. However much there could be problems here and there, but then we find ways in which we can deal with them. So, right. So today, again, let's look at this dyspnea. Some people call it dyspnea, dyspnea, etc. Okay, and how it is related to the chronic obstructive pulmonary disease. Okay, so here when we talk of dyspnea, we are talking of the breathing difficulty, okay, or what other people call the shortness of breath. And we are saying it's a hallmark symptom, okay, particularly during the exertion. When we talk of this, we are saying that it is a gold standard, or it is that symptom that you can look at and really start suspecting chronic obstructive pulmonary disease to be there. Okay, yeah. So a lot of factors lead to this shortness of breath. Okay, yeah. Things to do with lung elasticity, things to do with exercise intolerance, and etc. And really, managing this involves a lot of things to do with those corticosteroids, like we are told, and also some people get to points of supplemental oxygen therapy. Sorry, really, and also early detection and comprehensive management is able to help a person improve their quality of life. And we are saying that upper extremity activities pose a greater challenge than the lower extremity activities for these people with a shortness of breath. Okay, and also there is a oxidative, and also we are saying there is a oxidative stress. Okay, that can also contribute to the respiratory muscle dysfunction in cases when there is a severe uh, chronic obstructive pulmonary disease. And so this occurs when there is an imbalance in the production of those free radicals that are the reactive oxygen species, etc. Sometimes where free radicals pair with those unpaired electrons that can cause damages to cells, proteins, and also in the DNA. And also some people have argued that these are possible in causing cancer. However, for us in this context of the chronic obstructive pulmonary disease or the COPD, this can play a significant role whereby the chronic exposure to the cigarette smoking, like I told you, will bring these pollutants and which will lead to the accumulation of those free radicals that will start binding to those unpaired electrons in our bodies. Okay, this will lead to the damages and also other inflammations contributing to progression of the disease. That's why we're talking of being able to advocate for cessation of smoking. All right. So when we say risk factors and the comorbidities of the COPD or the chronic obstructive pulmonary disease, when we talk of comorbidities, we are talking of the other diseases, okay, that they are in. Okay, I hope you understand. Well, comorbidities are all what sometimes people have called them sometimes people have called them the opportunistic infections, etc. But really, we are looking at those other diseases that could be paired up with the COPD. Okay. So smoking is a primary risk factor, like we also that for this COPD, and also we are looking at genetic predisposition of this. We said that these metabolic syndrome diseases, or what we call vices, or what we call the example I gave you was that people with bad manners hang around each other. It is the same here. Good traits hang alone, and even people when a person is having good decisions in their life, they will move alone. For example, if someone is exercising, then really these people tend to know the benefits of exercise, and these people still tend to know that they need to eat a snack. These people tend to know that they need to watch their weight. These people tend to know that they need to take in fluids into their body. But if a person is not exercising, it is still this person who will be eating everything they find. Well, the other example I gave you was of a person who is drinking alcohol. And I told you still these vices or these uh, undesired characteristics work hand in hand. If a person is taking alcohol, what will they be doing? They'll be eating pork. They will be smoking, maybe talking to a woman, or doing adultery, or getting a prostitute. You understand all those things. So just to paint for your picture, it is the same with these really. For the people with a chronic obstructive pulmonary disease, they have these comorbid conditions like the hypertensions, the cardiovascular diseases, the diabetes, the osteoporosis, and really the metabolic syndrome, everything in it. That is why when we are managing these conditions, we tend to understand that if we don't manage those that are now very prevalent, if it is a hypertension that is prevalent, actually we will get a way of understanding what to begin with when things are, you begin with the most severe, okay? You begin with the most life-threatening. If a person comes presenting with four conditions, look at the one that is most life-threatening. For the issue of diabetes, we'll deal with the diabetes later. But there is there is stroke, there is hypertension. Let's deal with the things that are more life-threatening than the other. Okay, and we are also talking about cognitive dysfunction is common, and it is multifactorial, also linked to poor sleep, the fatigue, and also the depression from there. Okay, so what are we trying to do here? What is our treatment goal in this chronic obstructive pulmonary disease? Here is to alleviate or remove these symptoms and slow down disease progression, and also enhance the physical endurance. Remember, we said that exercises can also trigger the COPD. So the strategies, one is the smoking cessation. That one we can't emphasize it any further than that. Really, right now, all our hands are tied. We can't now give a person a leeway of them trying to reduce the cigarette smoking. However, also oxygen therapy for those hypoxemic patients, and lung volume reduction surgery in those selected cases. When we talk of these hypoxemic patients or hypoxemia, for example, we are talking about the low oxygen levels in blood, okay? Yeah, and which some people have called the hypoxia. And here, most of the tissues at the end of the day won't be able to receive enough oxygen. And it will result into the pneumonias, the asthmas, and even the high altitudes. These cases are more prevalent. And we are looking at you being able to identify those underlying causes and also involve that supplemental oxygen therapy. Okay. So, what are the pharmacologic therapies? We have the muscarinics, the bronchodilators to dilate the bronchus, and also the inhaled corticosteroid, the methylene, the methylcyanine. The word is becoming a little challenging. The methylxanthines. Okay, yeah, but really we are looking at increasing the pathway for the air to come in, and also to reduce the inflammation at the end of the day. So, what are the body composition and the weight status during this chronic obstructive pulmonary disease? We are looking at how weight correlates to this, and we said that really it is not only now evident, but it is well known, okay, that this weight, the body weight, will be a factor to consider when we are looking at the chronic obstructive pulmonary disease, and the relationship has been seen. However much there are a lot of things we will be looking at the body mass index, in this way, but weight correlates with the hospital outcomes of the COPD. For those who are a little underweight, then there are little successes about this COPD. But for those who are overweight, a lot of issues happen. For the malnourished COPD patients, these have a higher risk of readmission and mortality. Okay. And for the obese COPD patients, these are likely to be readmitted, are less likely to be readmitted or die compared to the normal weight counterparts. I hope we are clear with that one. For the obese COPD clients or patients, these are less likely to be readmitted. However, we also other literature are conflicting otherwise, trying to show that people who are underweight are not having a lot of blockages in their air pathways. Okay, but also, and they do not have a lot of comorbidities. But other people are also arguing that with this immunosuppression, as we will see, when a person is underweight, it will exacerbate the COPD further. So it is still a point of discussion, it's a point of understanding, but really it will depend on how the management has been done. All right, and we are saying that points, practice points, and core concepts. We are looking at the body mass index is a linear relationship with COPD or the chronic obstructive pulmonary disease mortality, and there is an association really, but not necessarily what we call a relationship. And we are saying this the relationship can be complex, and also there are other factors that could be there. Okay. This is what I see. At the end of the day, you might find that people who are underweight may experience more severe symptoms, okay, and are at a risk of death compared to those who are normal. With the normal weight, people with the normal BMI range, we are saying still this does not protect an individual from COPD. However, people could talk of that now there is a lot of evidence showing that overweight or obesity is actually already associated with a higher risk of getting this disease. Really, for those severely obese clients, we are talking of it leading to earlier progression, okay, and due to those breathing difficulties. I should say caution is needed in comorbidities and respiratory impairments. Okay, so let's look at cachexia. Sorry about that. We were saying let's look at cachexia. And we are saying cachexia is a condition where we're talking of individuals with advanced COPD may experience the loss of lean body mass, or what we call the LBM, and also muscle wasting, and even without significant weight loss. Okay. Yeah, really, whenever you see something to do with cachexia, you're looking at muscle wasting and weight loss. And this is due to things to do with the increased energy expenditure, where patients often have this increased energy requirement due to that. Now the lungs have to work twice as much because they want to, and also the systemic inflammation we associated with the disease. The lungs are working twice as much. So with this increased energy expenditure, when we talk of muscle wasting, could happen. And also reduced dietary intake, where we were talking of the fatigues and etc., and also the difficulty in eating, leading to that inadequate malnutrition, intake of foods and nutrients. Okay, so the cachexia and the preferential also of the lean body mass is independently associated with mortality. it can lead to death on its own. And also, despite having a fat mass, patients suffering with COPD do not experience a decline in fat mass with the disease's severity. It's not that you're going to start losing the fat, but the protein will start being lost because a lot of protein is required to repair those tissues that are destroyed due to the inflammation that is taking place. So the respiratory muscle strength correlates with weight and the lean body mass. Okay, when we talk of those pharmacological interventions, or what we call the medical interventions to increase the weight and the lean body mass, we are looking at the drugs like the megastriol acid and the anabolic steroids. These have been studied to increase weight and the lean body mass in this COPD or the chronic obstructive pulmonary disease patients. And also the beta hydroxyl methylene butyrate is a metabolite of leucine. I hope we all remember leucine from our what is that course unit called? Nutrition. I'm forgetting what it is called. We used to call it nutrient. What? I'm really forgetting. Yeah, but you know that leucine, which is the amino acid, okay, and it is an essential amino acids that the body does not must cannot produce on its own, but we get it from the dietary sources, okay, the meats, the eggs, the fish, the dairy products, the cheese, etc. I hope you remember. And we are saying these shows are promising preserving and also strengthening the muscle mass in the various populations, including those with chronic obstructive pulmonary disease. And we're saying further research is needed to determine the type of population and also the adverse effects and the optimal dosing regimens for these interventions at the range. Okay, so for the oral nutrition or the oral interventions for these chronic obstructive pulmonary disease, here we are looking at oral with the supplementation, all the issues to do with the body should be able to get its own nutrients traditionally, but here really we are on a life-saving scheme. Okay, yeah, positive signs in the COPD patients, including those with increased respiratory and limb muscle strength, weight gain, and also maintenance of the body composition. And also dietary counseling by the registered dietitians improves intake and maintains the body's composition, especially in the malnourished COPD patients. This is where you need to take your counseling classes seriously. The nutrition classes where you need to take those counseling classes are very key. Actually, people are eating off counseling. However much it's not supposed to be a money making venture, but it's the same thing that pastors are doing. They're trying to, as we go, balance saving scheme. Okay, yeah. So we also need to take into consideration almost all those religious leaders are doing. They're trying to as well, but also find ways in bringing you a bit at par with most of compared to what you have been doing gain. This increased energy expenditures due to physical activity. Okay, yeah. So we also need to take into consideration what are the number of minutes this person is supposed to be exercising for, the amount of calories this person is going to be burning, and how much of the supplementation is required, if any. And if no supplementation is required, can this person ably meet all those requirements? Okay, in a COPD or the chronic obstructive pulmonary disease, we are saying patients with compromised respiratory functions face barriers like early satiety. Before the person even eats a lot, they will claim to be full. Okay, they have this pseudo satiety coming in, and also physical exhaustion, and also the aerophagia, and the excessive swallowing of air, which could sometimes pose significant risks like food slipping a bit into the air pathway. So we find ways, if now the person is talking of early satiety, then I think we can indicate an increasing on the meal frequency, giving this person small bits of the foods, but over a longer period of time, so that we work on this. And also, as strategies to improve intake include adequate fluid intake, the small frequent meals, the rest before meals, and also consuming those softer foods. But also being able to talk to our client, being able to understand what are those foods this person wants more. Because if we begin by the foods that the individual wants most, there is more sustainability in these choices because it's not coming from us as nutritionist. It's coming from the individual themselves. They are on what with their lives and beginning with the foods, if it is the eggs, if it is the meat, etc. So that we can try as much as possible to improve the intake. Also, making community food programs and social food systems for assistance with grocery procurement and meal preparation. You know, sometimes what kills clients or what makes clients deteriorate is that loneliness, is the isolation. That's why you see at the end of the day, they expect it is only actually people are talking of that time when we had COVID 19, when there was that pandemic, when it was everywhere, when now the spikes were really high in the number of cases. It is believed that people died of loneliness. Okay, people died of being isolated. When a person is alone, there is no social support, there is no emotional support. A person can no longer fight. They have lost the will to fight on and on. But if there are social support groups, if a person is suffering with obesity, but he's not suffering obesity alone, there are other people who are similar. It is what the other people are going through. They can make we can use these as role models. People can be role models of others. People can learn from their peers. So it is very key and crucial. Whenever you're having these clients, if you have a success of a client, always refer your client to that client that you had a success with. Okay. I know that sometimes we can get those clients that are like, okay, I gave you my money. I'm not supposed to be teaching another client. But really, those are very rare cases. It is actually very imperative that a person who is now well, who is at optimum health, is able to help someone who is suffering with what this person was suffering from earlier on. Okay. So when we talk of the acute renal respiratory distress syndrome or the ARDs, we are now done with the chronic obstructive pulmonary disease. Now we are looking at the acute respiratory distress syndrome. Here we are saying it is characterized by bilateral lung infiltrates, and that is when we are looking at the low partial pressure of the oxygen fraction inspired ratio. Okay, yeah, and also the systemic inflammatory response. So the mechanical ventilation and oxygenation strategies and fluid restriction and management of acidosis are key treatments for this acute respiratory distress syndrome. Okay, when we talk of this partial pressure of oxygen, we are looking at the amount of oxygen that is dissolved in the blood. And when we talk of that fraction, which you can see the FiO2, we are looking at the fraction of inspired oxygen is the concentration of oxygen delivered during mechanical ventilation. Okay, yeah. So we are looking at that ratio. The low, if that ratio is low, the ratio of the partial pressure oxygen and the fraction of the inspired oxygen, really we start suspecting acute respiratory disease syndrome, and also that systemic inflammatory response. So we've looked at the mechanical ventilation and oxygenation strategies being key in management and treatment of this acute respiratory distress syndrome. And also we are looking at nutrition playing a vital role in managing this acute respiratory distress. But estimating energy needs can be a little challenging due to those comorbidities like we had seen and the various medications that are being indicated to that individual. But then indirect calorimetry or validated equations are recommended for estimating this energy needs. And also attention should be paid on carbohydrate intake to avoid overfeeding, which can worsen the respiratory function by increasing carbon dioxide production. Remember, carbon dioxide is one of the byproducts or the waste products of metabolism of carbohydrates, I should say. Okay, so for the nutrition support in this acute respiratory distress syndrome, we are looking at enteral nutrition. I hope you remember. And we're saying this is recommended for patients with ARDS, especially those who will benefit from fluid restriction, and also for patients typically fed entirely using that supine in the supine position. Remember that position, but prone positioning may be used in select cases to improve gaseous exchange. So enteral nutrition in prone position appears to be safe and will not significantly increase the complications compared to the spin feeding. Really, that is what we are trying to talk of here. That when there is now nil by mouth, we tend to talk of the prone positioning, and here we are looking at giving a person this feed entirely while the person is lying with the face down or with the stomach down against the bed on which they are sleeping. But then you remember when we were talking of that supine position, we were looking at individuals were facing upwards. I hope you remember that one. Okay, yeah, or horizontally on one's back. Okay, when someone is looking up. But for this prone position, you remember it was more when there was the COVID-19. People were advised to lie facing down. And we are also looking at other nutrition strategies or nutrition support for people with this acute respiratory distress syndrome. Various strategies like the head over bed elevation, the prokinetic agents, the post-spiralic feeding may be used to optimize the enteral nutrition delivery in these ARDS patients. And no specific recommendations regarding intentional weight loss in the COPD, or what we call the chronic obstructive pulmonary disorder or disease. So, friends, let's now interest ourselves with what we call immunonutrition. Okay. So, friends, when we talk of immunonutrition, we are looking at this involving those specific nutrients to modulate the immune response. Okay. Yeah, we are using those nutrients that want to help us in the body's defense mechanism against the infections, the inflammations, and also those other immune-related disorders, as you will see. Point to note that all nutrients are crucial, but we are looking at those that are more at the forefront in helping us fighting these diseases, all this inflammation, all these disorders, I should say. For these specific nutrients, we are looking at the study has looked at the studies have investigated use of omega-3 polyunsaturated fatty acids and the gamma lipid. The GLA is the gamma lipid something, I'm forgetting, and the antioxidants in this acute respiratory disorder syndrome. Okay, yeah, patients. For the immunonutrition, we are looking at really most of these things, we are looking at the proteins, okay, being able to help us really work on the inflamed areas. We are looking at those probiotics. We are looking at the vitamins and minerals. We are looking at the omega-3, like we talked about, those that are found in the fruits, not in the fruits, sorry, in the fish, in the walnuts, etc., that have those anti-inflammatory properties. We are looking at also the antioxidants, things to do with the vitamin C, E, and selenium and zinc. And also we are saying entire formulas enriched with these nutrients have shown to have the benefit for the ARDS patients, and also improved oxygenation, reduced ventilator days, and also a shorter ICU, intensive care unit stays. And also this has proved to lower the mortality rates compared to control formulas. And also, there is a controversy that exists due to variations in the fatty acid profiles and the antioxidant content. So the antioxidants we've seen, the vitamin C, E, and A, the carotenoids, these protect the lung function by reducing that oxidative damage. Okay, yeah. So then there won't be a lot of unpaired electrons if these antioxidants are more. And also studies have shown mixed results regarding this antioxidant supplementation in the COPD and asthma. And also high quality diets rich in antioxidants have shown to have benefits for lung function. All right, vitamins and minerals, we have looked at phosphorus and magnesium, the selenium, ZTC for the adenosine triphosphate production and bronchodilation. And the vitamin D deficiency is a common or is common in these conditions of the chronic obstructive pulmonary disease and asthma. So the correction of these deficiencies may help us mitigate those comorbidities like the osteoporosis and also the depression that could come at the end of the day, and also improving the quality of one's life, and also the other factors like the impaired lung function, the depression, the underweight status. These are really negatively impact the quality of life of these people suffering with COPD. So for vitamins and minerals, we are looking at malnutrition videos report greater levels of fatigue and compromised physical function. Okay, and supportive measures and maintaining a healthy lifestyle are crucial for improving quality of life. So really, friends, today we have been looking at the respiratory system, I should say, beginning with the chronic obstructive pulmonary disease, looking at the asthma, the diagnosis, the signs and symptoms, how nutrition could help us, going to the acute respiratory disorders, or I should say, and the acute respiratory distress syndrome, sorry, and how we could indicate the enteral feeding and what to look out for in this particular case. So, friends, I believe this brings us to the end of our today's engagement. Unless there is anything else, I beg to stop here today. Yes, do we have anything? Oh, am I audible or have been speaking to myself for a full hour?
You have been audible, sir.
Oh, okay. I'm going down with some bit of flu, so I'm not so sure about that delivery.